Welcome to the Cardiovascular and Respiratory Systems Assessment Program. This program is provided by the Beacon Institute through a grant from the Office of Healthcare Quality. This program should enable you to list age-related changes to the cardiovascular and respiratory systems, describe the components and techniques used in the assessment of these systems, and identify and discuss abnormal assessment findings related to assessment of the cardiovascular and respiratory systems. Cardiovascular and respiratory changes that we often see with aging can result from the aging process, lifestyle, and/or disease. It is important to know which factors are generally attributed to aging versus disease so that you can recognize normal changes that are expected. The cardiovascular system is comprised of the heart and blood vessels. Changes occur in both with the aging process. This slide focuses on changes to the heart, which is responsible for pumping blood to the body. Age-related changes can affect the electrical system, which controls the heart rate and rhythm. Age-related changes also affect the valves and the pumping action of the heart, both of which affect blood flow. The valves generally affect flow through the heart, and the pumping action affects blood flow to and from the body. The aging process can also cause changes in the blood vessels. Arterial changes affect blood pressure, and venous changes affect return of blood to the heart. Changes in the reflex mechanism also causes problems with the vasculature response affecting blood pressure regulation. This increases the risk for hypotension with postprandial and postural changes. As the slide shows, there is stiffening of the arteries, the veins become thicker, more dilated, and less elastic. There's altered baroreflex mechanisms and less effective blood pressure regulation, especially with the postural changes, which can cause orthostatic hypotension and, as mentioned, the postprandial hypotension. Typically, the effects of these changes are not experienced with normal daily activities. They become more apparent with increased demands on the heart, such as with exercise. It takes older adults longer to recover from tachycardia, so consider the activities that occurred prior to the time of the assessment. As to the respiratory changes, the ribs form a cage around the lungs. If the cage remains rigid, the lungs are constricted in their movement. Also keep in mind that changes in posture or spinal curvature can also affect lung expansion. It's hard to expand lungs when the body's in a stooped position. The effects of age-related changes are limited lung expansion, increase in dead space, and a decrease in vital capacity. There is a tendency for more shallow breathing, which increases the risk for infection. Vessels in the lungs undergo the same changes that occur in the rest of the body and can have an impact on respiratory function. For example, narrower, more rigid vessels in the lungs can interfere with adequate exchange of gases. Air sacs lose their shape, leading to trapped air, reducing the efficiency of gas exchange. The trigger to cough is less sensitive, and the cilia activity is less efficient, leading to difficulty removing irritants and secretions. There is a weaker immune system, which makes the older adult more vulnerable to infection, particularly lower respiratory infection. These factors contribute to older adults being 5 times more likely to die from pneumonia than other age groups. There is decreased response to low levels of oxygen and high levels of CO2. Older adults are more likely to show mental status changes versus breathlessness when the blood gases are abnormal. Just as with the cardiovascular system, age-related changes to the respiratory system don't generally cause problems under normal circumstances. Issues occur when the person is under stress. And to repeat, older adults are at higher risk for respiratory infection. Pneumonia can have deadly consequences. Now let's look at how to assess these systems. To prepare for the assessment, review the information that you have available, such as history and physical, hospital discharge summary, medication list, diagnostics, etc. Knowing the history and what problems the person has had will guide you as to what questions you may want to ask or particular things to observe. Identify if there is a recent electrocardiogram and blood work, including a C-reactive protein, CRP, screening. CRP is a marker of inflammation that is a stronger predictor of cardiovascular events than low-density lipoprotein, or LDL, cholesterol. You will be using multiple techniques in gathering assessment data. Keep in mind that you can be performing the interview as you perform the physical assessment. Lifestyle impacts both cardiovascular and respiratory function, so the answers to these questions can give you vital information. Do you smoke? Have you ever smoked? If the answer is yes, obtain facts such as how long, how often, how many packs per day. Do you follow or have you ever followed a special diet? If so, what kind? Explore the typical eating pattern, the usual foods that are consumed. Do you exercise? And if so, what type? How often? For how long? Are there any problems tolerating exercise? What is your usual daily routine or activity? Have there been any changes in your activity level? These questions explore problems with cardiovascular and respiratory function. Please note that if the response is yes to these questions, gather as much information about symptoms as you can. As noted by the asterisk, if the answer is yes to the questions, gather details related to symptoms. For instance, with pain in the legs, look for intermittent claudication. Swelling, wheezing, coughing can be telling of heart failure. Have the resident describe the expectorant if the cough is productive. If breathing problems occurred during sleep, get as much information as possible as to the incidence, frequency, severity, and other characteristics. Don't forget to ask about respiratory issues related to sleep. There is a close association between sleep apnea and cardiovascular conditions, such as hypertension, heart failure, arrhythmias, and stroke. If a person has high blood pressure or heart failure and sleep apnea, treatment of the apnea also often improves these conditions. Cardiovascular symptoms associated with low oxygen levels during sleep triggers mechanisms to tighten up the blood vessels to help increase the blood and oxygen flow to the brain and heart. These triggers tend to carry over into the day as well. Inspection involves visual survey of the body, looking for normal structure and function. Color is an important sign in cardiovascular and respiratory assessment, but it's often not included in the documentation. If there is not a drop-down menu or box to check, please add it to your notes. Energy may also be an indicator of cardiovascular and respiratory function. Pay attention to breathing. Is it easy? Are accessory muscles being used? Is breathing shallow, deep? Are there sounds associated with breathing? If there's coughing, is it wet or dry, productive or non-productive? Is there even expansion on both sides of the chest? The color and condition of the extremities tells a story about cardiovascular function. Clubbing of fingers indicates problems with decreased oxygen levels in the blood. Dry, brittle nails can be a result of dehydration, but can also indicate problems with vasculature supply. Look at capillary refill. It should be less than 2 seconds. Delayed refill could indicate Raynaud's, which was the constriction of capillaries of the fingers and toes. can also indicate shock, dehydration, reduced circulation to the peripheral vasculature. Varicosities can indicate problems with the valves in the venous system. Upon standing, the blood flows down versus back up to the heart. If edema is present, note the amount and extent. Is it pitting, and to what degree? To measure edema, press on the skin and note if an indentation is made. Press along the area to the point in which swelling is no longer present. You can determine the degree of pitting edema by the length of time it takes the skin to rebound after being indented and the depth to which you could indent. This slide has combined two similar scales noted in the references. Hogan provides the millimeter measurements, which helps to take out the nurse subjectivity. When assessing the vessels, check rate, rhythm, quality. You don't have to check every pulse point for every assessment, but if you are concerned about perfusion to a certain area, check the pulses in that location. Don't forget to record rhythm and quality along with rate. This gives information about the function of the heart. Differences between apical and radial pulses, known as the pulse deficit, could indicate perfusion problems. Some tachycardia could be present due to resident activity prior to the exam. If tachycardia is detected, reassess the person again at a later time. Carotid pulse is the last place you can feel a pulse if the blood pressure is too low. If a person is conscious, you should know that they probably do have a carotid pulse. The jugular vein usually is not distended when the person is at a 45-degree angle. If you see distension, shining a light on the jugular vein helps to see pulsations. If pulsations you see coincide with the radial pulse, they are not jugular venous distension. Jugular venous distension pulsations occur with several waves with each cardiac cycle. This could indicate constrictive pericarditis, which is infection lining the surrounding of the heart, or cardiac tamponade, which is fluid in the sac around the heart. These conditions restrict the volume of blood in the heart. This could also indicate right-sided heart failure due to blood backing up in the veins. When examining major arteries, make use of both sides of the stethoscope. The diaphragm, which is the larger flat disc, is used for higher pitch sounds, and the bell, the smaller side of the drum, is used for lower pitch sounds, such as murmurs. Make sure that you reduce environmental noises. For instance, turn off TVs and radios and close the door to optimize your ability to hear. When assessing blood pressure, be sure to use the right size cuff. Too small a cuff can cause a reading higher than it should be. Too big a cuff, a reading lower than it should be. If the resident is seated, assure that he sits properly, no crossed legs, and the arms supported. It's helpful to take more than one measurement. Be mindful of those things that can increase blood pressure. Wait at least 30 minutes after those activities before measurement, or recheck the person again after 30 minutes. Note pulse pressure, which is the difference between the systolic and diastolic numbers. 40 is considered normal. Low pulse pressure indicates poor heart function. High increases the likelihood of a cardiovascular event. Taking the blood pressure in lying, sitting, and standing positions is needed to identify orthostatic changes. Drops of more than 20 millimeters of mercury between position changes are significant. Observe the chest. Look for how the chest expands during inspiration. It should be equal on both sides. Look at the shape of the chest. Some barreling may occur with normal aging, but note any skeletal issues that affect breathing, such as abnormal curvatures of the spine, which can change the size and shape of the chest cavity and can impact breathing. Look for scars and ask about surgeries related to the heart and lung. Look at color. People who have had chronic respiratory disease often have a ruddy complexion. Listen to the heart. Abnormal sounds are best heard with the bell portion of the stethoscope. Listen for breath sounds. For the resident's comfort, warm the stethoscope before placing it on the resident. Place the stethoscope on the bare chest. Clothing can cause problems with acoustics. Listen at the intercostal space. The stethoscope over the bone will muffle breath sounds. Compare the sounds bilaterally. These are examples of more common abnormal breath sounds: crackles or rails, rhonchi, and wheezes. There are many resources available online that allow you to hear what these sound like. Palpate the chest to detect fremitus, which are vibrations felt through the chest wall when the person speaks. Using the ulnar surface of your hands, place your hands on both sides of the resident's chest at the area at the top of the lungs and ask the resident to say 99. Then move your hands down along other areas of the lungs and repeat. Fremitus is normally best felt in the upper lobes. Reduced fremitus in the upper lobes can be associated with COPD, pleural effusion, or pneumothorax. Increased fremitus can occur with pneumonia or a mass. Percussion is tapping on the body's surface to determine the underlying structure, size, and consistency of organs and the presence of fluids. Place the middle finger of your non-dominant hand firmly on the chest of the resident over an intercostal space. Using the middle finger of your opposite hand, tap over the distal joint of your finger that is on the chest several times. The tapping motion should come from the wrist, not the movement of your whole arm. Percuss the lungs over the intercostal spaces. Start at the top of the lungs and move to the bases, comparing. Note the sound that's produced. Repeat for the opposite side. This slide lists abnormal findings that you should report. When you note a change in condition, complete the concurrent review or SBAR. Clearly identify the change. Include the approximate time and/or the related activity. Document all assessment findings. Do not rely on the boxes and drop-down menus alone. Include additional information in the notes. Document care, treatments, and other activities as soon as possible after they were provided or occurred. Include the times as appropriate. Document effectiveness and outcomes of care and treatment. Document conversations with the nurse practitioner or physician and note what was discussed or reported. Note the times that phone calls were made and answered. Keep your supervisor informed of condition changes. If you have any questions, please consult with your staff development educator or your supervisor. Thank you for your participation.